In this lecture, we will try to organize our knowledge around a very important aspect in our career. So that is pain and analgesia. What we mean by analgesia is pain relief. So all of us should have a thorough knowledge and good practical skills as medical personnel about pain and pain relieving methods. What should you know about pain at the end of this lecture? So at the end of this lecture, you should know what pain is. You should be able to give a simple definition about pain. And you should try to understand the importance of recognizing pain and managing pain. In short, why should we treat pain? And thirdly, we should know how to assess pain. And finally, we should know how to manage pain. So, what is pain? Pain has many definitions given by different authorities, but the most widely accepted definition for pain is the definition given by IASP, International Association for the Study of Pain. And according to that definition, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is a protective reflex. It will protect us from different kinds of injuries, damages that can happen to the body. And pain is the commonest symptom in the world. It's the commonest complaint by patients and is the commonest reason for a patient to come and see a doctor. Unfortunately, at the same time, pain is the commonest symptom ignored by medical staff. So pain reduces functions of a person, his or her activities, and the quality of life. Uh, so talking about this ignoring pain by the medical staff, for example, sometimes patients come and complain to a doctor about the pain that the patient is having. But with time, the patient, although the patient's problem is pain, doctors and the other medical staff will start following a possible cause for pain and ignoring the fact that patient is in pain and forgetting to treat pain. So it's good to look for a cause for pain and treat the cause, but at the same time, doctors should remember to treat pain. That is the very reason that the patient has come to see you. So this is a picture of a pain team gathered around a patient and trying to manage the patient's pain. Now, so this is something that you will see commonly in the developed world. Now, in the developed world, all the hospitals have a separate department called Department of Pain Medicine. So, like other departments, for example, all big hospitals of a developed world would have a department of uh, dental surgery, a department of oral and maxillofacial surgery, a department of anesthesiology, a department of cardiology, a department of respiratory medicine. So like that, there's a separate department called Department of Pain Medicine, and that pain managing team is led by a dedicated pain consultant, and with him there are postgraduate trainees like fellows, senior registrars, and there are nurses. There's a separate place for this pain management team. They have a pain office, pain management unit, a separate pager and a telephone to be contacted by the rest of the hospital. Now let's see how we can assess pain. So there are different dimensions or different aspects of pain that has to be assessed or looked at. For example, type of pain, whether this is a cancer pain or this is a pain due to a chronic arthritis or this is a pain due to a pneumonia and so on and so forth. And location of pain. So where exactly is the pain, whether it's a headache or neck pain or head and neck both, or it's in the lower jaw, or where. And the nature of pain. For example, whether this is a uh, chronic pain related burning type of pain. Oh, whether this is a uh, patient is feeling as a sharp cutting type of pain, like when it is associated with an acute trauma or soon after a surgery. And another thing that we can assess is the duration of pain, whether the patient has been there for a few days or a single day, a few hours, or several months. So if a patient has been there for more than 3 months, we generally call it a chronic pain. And acute pain is what we frequently encounter, like a patient after a trauma or after a surgery or after a medical procedure. Then we can also see how it affects a patient's life. Say, for an example, whether pain has affected the patient's mood, and how it affects the patient's day-to-day life, patient's sleep, appetite, etc. Then another very important thing that we have to assess is intensity of pain. How much of pain is felt by a patient? So now there are different methods that can be used to assess pain. So we can divide them broadly into two categories as subjective methods to assess pain, pain intensity, and objective methods. So subjective methods are, um, for an example, a doctor can ask a patient, say, how much of pain do you have, whether you have mild pain, moderate pain, or severe pain. So now there's a problem with that way of assessing pain, because what we ask is a relatively subjective question, and the patient's answer invariably is also going to be a subjective answer. And whether we can assess pain precisely with subjective methods is a question. For an example, if three doctors go to a person and ask how much of pain do you have, now the patient might say, I have mild pain. By listening to that answer, one doctor might feel, okay, so although the patient said he has mild pain, I feel the patient has a lot of pain, although he answered like that. So that's what one doctor feels. And another doctor, the second doctor who listened to the same answer, would say, well, he doesn't seem to be having a lot of pain. So he just answered because you asked whether he has pain. And the third doctor who listened to the same question might say, no, he doesn't seem to be having any pain at all. I don't think he has pain. Right? So now a patient has given a simple answer, and doctors ask a simple question, and well, the answer we got and our assessment way is relatively subjective. Now at the same time, we have methods to measure or assess pain in a very objective manner. For an like when you are recording the blood pressure of a person, for instance, if you go and ask a nurse what is the blood pressure of this patient, the nurse might say this patient's blood pressure is 190 by 88. So that's a very precise way of assessing something. Or one of your colleagues uh, calls you and say, uh, the patient in bed number 6, he has a very low oxygen saturation. His oxygen saturation is 88% on room air. His respiratory rate is 8 per minute, and he doesn't deep breathe. I checked his tidal volume through the spirometer, and his tidal volume is only 250 milliliters. Now all these are giving measurements in a very precise way. So, and with that kind of very objective assessments, you can plan your management of a patient more precisely. So likewise, there are methods to assess pain also in a more objective manner. For an example, uh, we have pain assessing scales. There are many scales that can be utilized for assessing pain in different circumstances. So visual analog scale is one situation where you can show a patient a small instrument where there are different patient can point where he has pain on that scale. A numerical rating scale is a well validated bedside pain assessment tool where you ask the patient to express his pain on a simple numerical scale. So the scale would range from 0 to 10. So for an example, you can tell the patient, if you have no pain at all, your pain score is 0 out of 10. If you have the maximum pain in the world, the maximum pain that you can think of, it would be 10 out of 10. So where is your pain standing now? Whether it is 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let's say the patient says, for example, in a patient who is after surgery in the maxillofacial ward. So the patient says, my pain is 9 out of 10. So now, you know the patient has a lot of pain. So you can use several analgesics on this patient to control the pain. For example, you can use a subcutaneous dose of morphine, 0.15 milligrams per kilogram body weight, and at the same time you can give him a tablet of oral diclofenac sodium, 1 milligram per kilogram body weight, or use a rectal diclofenac sodium suppository, 1 to 2 milligrams per kilogram body weight, and at the same time you can give paracetamol orally, 15 milligrams per kilogram body weight. And after half an hour you come and ask the patient, how much of pain do you have now? Now the patient might say, well, now my pain score is 2 out of 10. So now you have measured the pain objectively, and you know it was 9 earlier, it is 2 out of 10 now. If you come and ask the same patient about how much of pain has he got after another 6 7 hours, now he might say, now my pain score is 7 out of 10. So effects of the analgesics that were given initially have worn off, and now he's getting more pain. So now you can give a new set of analgesics, or repeating them after a particular interval, and control pain. So why should we treat pain? Why should we treat pain as doctors? Why should we learn regarding treating pain? Because pain affects entirety of a man. So pain affects all aspects of a human's life, and it affects the society, it affects our health system. For example, pain affects physical health of a person, mental health of a person, social health of a person, his personal life, family life. For example, if the father of the family is in severe pain, he is in excruciating pain, he cannot go to work. So his physical health is affected. We will learn about how pain will affect a person's physical health in the next few slides, and he will be mentally down. He may be depressed due to severe pain. So his health has been affected. His social health has also been affected. So he probably is getting angry with children and the wife, and he's unhappy at home, or he may quarrel with the next door neighbor because he's suffering from a severe pain, and his personal life is affected, his family life is affected, and he's not going to work, so workplace is affected, or he goes to work and does not work properly because he's in severe pain, or let's say he has a headache, and his income is affected. If he does not go to work, he would not be earning. Think of a casual worker who has to go to work every day. Think of a mason or carpenter or laborer who will earn only if he goes to work. Otherwise, he's not. If he's a farmer, if he will earn if he goes to work only. Otherwise, he's not going to get a salary or an income for that day, and that will affect his whole family, not only him. And the entire health system is also affected. Let's say you have several patients whose pain is not controlled properly, so they cannot be discharged home, so they are at the hospital, waiting in the hospital, admitted in the hospital for an unnecessarily lengthy number of days. So that will affect the bed occupation of the hospital, that will increase the cost of that hospital, and it will indirectly affect the country's economy. So for an example, if several people of uh, the workforce is not attending to work, that will have a serious negative impact of the country's economy. So we should treat pain of humans and even other animals on humanitarian grounds. So we do not have to be even members of health staff to do that. Anybody can get involved in managing pain of another person. So Even in the constitution of Sri Lanka, there's a clause saying that being free from pain is a human right. So if we are not treating someone's pain, we in fact are violating the constitution of this country. Look at the photograph of this person. So he obviously has sustained a massive maxillofacial injury. His face, mouth, nose seems to have been injured heavily, and obviously his airway has been attended by the medical staff. He has had a tracheostomy. You can see an opening into the trachea in the neck. So A is sorted out. Then looking at B, his breathing is being supported by an bamboo bag. C, circulation, there are some ECG leads and he may be having an IV drip. D, disability, he may be unconscious or conscious. Either situation, he's having pain. So it's our duty as health person, if we see a patient like this, or even a person with minor injuries, to see soon after sorting out airway, breathing, and circulation, very important vital parameters, to see whether the patient has pain and if so, to relieve pain. Now let's see how pain can affect one's physical health. So we mentioned earlier that pain can affect entirety of a man: physical health, mental health, social health, his personal life, family life. It can affect his workplace and all aspects of a human life. Now if we start analyzing what pain can cause in a person's physical health. So one of the first things that we can see is pain will lead to activation of sympathetic nervous system, leading to tachycardia or increased heart rate, hypertension, and tachypnea. And these obviously are not very helpful for a person when he's trying to cope up with pain. Pain can also affect the cardiovascular system adversely. So, for instance, presence of pain will increase myocardial oxygen consumption. Hence, it can precipitate an anginal attack. It can precipitate myocardial infarction or heart attack. It can lead to arrhythmias, which may be fatal. It can worsen cardiac failure, especially in a person who already has cardiac failure. Also, pain will lead to a special stress response called stress response to pain. So we know patients have a stress response for illness, for trauma, for surgery, and we call them stress response to illness, surgery, or trauma. And these stress responses also will get worsened due to pain. In addition, stress response to pain has proven to be several times greater than the stress response for surgery, trauma, or illnesses. Pain will lead to reduced mobilization, which all of us know can lead to deep vein thrombosis. And if a clot from a deep vein thrombus gets dislodged and go and get stuck in the lungs, we call it pulmonary embolism, which can lead to even a sudden death, or which can lead to respiratory failure, cardiovascular collapse, and will increase morbidity of the patient. And reduce mobilization. Or let's say a patient is on the bed all the time, not moving due to pain. They can end up in a special type of pneumonia called hypostatic pneumonia or orthostatic pneumonia. Some a type of pneumonia that a person can get when they're lying flat on a bed. So bedridden patients can get this hypostatic pneumonia. Then pressure sores. Sometimes we call them bed sores. When a person is on the bed all the time, they can have sores or ulcers under pressure points of the body. And there can be muscle wasting due to reduced mobilization, and there can be even wasting of bones, which we also call osteoporosis. Then reduce depth of breathing, reduce cough, is something that can happen with pain, especially if the pain is in the chest or the abdomen, because every time patient breathes, it's going to cause pain. Hence, the patient learns not to take deep breaths and not to cough. So it's largely spontaneous reaction. It's a reflex from the body. Anyway, all these can lead to atelectasis or collapsing of alveoli, which can lead to hypoxia, ventilation perfusion mismatches, and reduced cough and reduced breathing together can lead to retention of respiratory secretions, and finally that can lead to respiratory tract infections, lower respiratory tract infections and pneumonias. Pain will also lead to urine retention. Now, all of us know to pass urine, we need the activation of the parasympathetic nervous system. And earlier we learned pain can lead to uh, dominance of the sympathetic nervous system. Then obviously the patient is going to get a urine retention. And pain will also lead to reduced gastric emptying, delayed gastric emptying, can lead to gastritis, peptic ulcers, gastric ulcers. It will also hamper gastrointestinal motility, can lead to even abdominal distension, and constipation also can happen due to pain. Then pain can affect the mental health also very seriously. So pain will lead to mental stress, depression, and stress and depression increases pain further. We know when somebody is in an if a person is very happy, in an elated mood, euphoric, pain will be less. But when somebody is depressed, sitting in a corner, unhappy, stressed out, then their pain will be more. So stress and depression will generate more pain. And pain will also lead to anxiety, restlessness, fear, unhappiness, unsatisfied about even whatever the other treatment that you are doing. Pain can lead to reduced sleep, loss of appetite. Pain can lead to disabling chronic pain syndromes. So chronic pain is altogether a different disease. It's now considered as an entirely different disease, an entity in the new classification of diseases. So unlike acute pain, chronic pain is very, very disabling to a person, and it's a trouble to health staff. So chronic pain patients, if they have developed a chronic pain, they will be very resistant to treatment. They will go from this doctor to the other hospital, from this hospital to another consultation office looking for relief. So chronic pain is something that cannot be treated easily, and so every time you do not manage acute pain properly, you are increasing chances of somebody getting a chronic pain. So it's very important that we try to prevent chronic pain syndromes being developed by tackling pain in its early stages in a very effective manner. Pain will also lead to salt and water retention of the body. In addition to chronic pain syndromes, pain can also lead to development of post-traumatic stress disorder (PTSD). So pain finally will lead to reduced quality of life for persons, loss of work, reduced productivity, and a person who is suffering in pain is a burden to himself or herself, a burden to the family, a burden to the workplace, burden to the society, and to the country. And so it will affect daily living, self care, and virtually everything, all aspects of life of the person who is suffering and the nearest members of his family or people who are very close to him in a working place. Everyone's life will get affected if a person is in severe pain. So if we look at patients whom you get in the hospital setting or clinic, they will be coming with some kind of primary injury. So maybe with a head injury or maxillofacial injury or spinal injury or chest injury or burns or myocardial infarction or any other medical problem, which we call the primary injury. So the primary injury has already happened by the time the patient comes to you. You can't prevent the primary injury. You can't avoid the primary injury. It has already happened and the patient has come to you now. So all what you can do about the primary injury is you can treat it. And at the same time, we should try to avoid secondary injuries. Secondary injuries will be uh, even disabling. Now, for instance, the patient can develop hypoxia, hypercarbia, hypotension, infection, and pain as secondary injury. So, pain is one of the secondary injuries that can happen to a patient. So, when you get a person with a primary injury, while treating the primary injury, try to avoid secondary injuries being developed. So, you may put the patient on a oxygen mask. You may start him on a IV drip. So consider pain also as a secondary injury and try to treat it, avoid it. So now we know pain is a priority in management of a patient. So pain is not something that you can ignore, forget, keep in aside, do everything else, not attending to pain. No, it's not like that. Pain is a priority. Like you attend to airway breathing circulation of a person, you should also attend to pain. Look at the face of this person who has some injuries on his face. So we might not see the previously mentioned complications that can come up due to pain all the time. So sometimes what we mentioned earlier will be ignored by the medical staff, or we may not attribute it to pain. For instance, a patient like this may be tachycardic, may be hyperventilating, may be tachypneic, and may have anything else that we discussed in the previous few slides as complications due to pain. But due to poor knowledge about pain, lots of medical staff ignore those things, and they might not see those things, they might not detect these things. So pain is largely underdetected, not recognized by health staff, unfortunately. So at which stage in patient care should we assess and treat pain? The big answer would be at all times. In all stages of pain management, we should try to recognize presence of pain, we should try to assess pain, we should try to treat pain. So for instance, from the point where you are collecting a patient from trauma, we call it extrication. From the extrication from a site of trauma, or picking a patient from home from an ambulance if he's in a serious medical illness, from that point onwards, it's the duty of the health staff to control pain. So during transfer to the hospital, and soon after bringing the patient to the OPD or emergency department, and during transfers of the patient within the hospital, let's say the patient is being taken for x-rays or CT scan or for some other investigation, or when the patient is being moved to another unit from the emergency department, and also after admitting the patient to a ward, it may be a medical ward, surgical ward, a gynecology ward, or even after admitting to the ICU, during a surgery or during any other medical procedure, and soon after that in the post-operative ward or in any other ward. Hence, in all stages of patient management, we should manage pain, because pain will lead to all kinds of problems. So we have already discussed about 10-15 things that can happen due to pain. In addition to that big list, there are many other adverse things that can happen due to pain. I told you earlier, we should think about managing pain even from extrication from a trauma site. So for instance, if the car driver and the other passengers of this car, obviously they may have undergone heavy injuries, so soon after taking them out from this vehicle, while giving oxygen, while attending to their breathing and circulation, we should think of giving pain relief, and maybe we can give an intramuscular dose of ketamine, and or some other form of analgesic. And like here, during transfers within the hospital, again, we should, and when the patient is undergoing a surgery or any other procedure, it's the duty of the anesthetist or other doctors who are performing the medical procedure to attend to pain of the. So pain is a vital sign, like airway, breathing, circulation, and disability. It's a vital sign. So pain can be regarded as the fifth vital sign, or you can consider pain as part of managing disability. So what we refer to as disability is level of consciousness, pain, size of pupils, and random blood sugar. So either under the fourth element, under disability, you can consider and treat pain, or consider pain as the fifth vital sign, whatever, it doesn't matter. Uh, think about pain, assess pain, and start treating pain. So consider pain as a vital sign, because if pain is not controlled properly, it can lead to all sorts of problems. So we have discussed some of those problems earlier. Now, why is pain often not attended to properly by the health staff? So one reason is underassessment of pain by the staff. So as I mentioned earlier, if you do not assess pain, you would never know that there is pain. So sometimes what happens is staff just assumes that there's no pain in this patient just because the patient is not crying or not shouting or not complaining. It does not necessarily mean that the patient has no pain. The patient may be suffering silently in pain. So all patients would not shout, all patients would not cry. So don't think only the patients who make a fuss or who are considered as troublesome to the staff only have pain. Generally, all our medical procedures, all operations, all traumas will lead to pain, whether the patient complains or not. So, under assessment of pain is a huge problem with regards to pain management. So, please see whether your patient has pain. Just check with him. Another reason why patient is staff is not attending to pain properly is the staff is being distracted by injuries and instabilities that the patient has. For instance, if a patient's blood pressure is very low, if he has bronchospasms, or if he has some other thing, let's say he has a bleeding from a wound, so the staff is concentrating on those injuries and instabilities and forgetting the fact that patient has pain. Another big problem is opiophobia. So staff, although medical staff is a staff that knows a lot about opioids, like your morphine or pethidine, their desired effects, their side effects, how they act. So we know all those things, but the staff has an opiophobia. They are reluctant to use opioids. Although opioids are very strong analgesics, they try to avoid opioids considering their side effects. There are many other reasons why staff withhold analgesics or try to avoid painkillers on patients. So, one reason is fear of respiratory depression, especially when they have to use opioids like morphine, pethidine, or fentanyl. So, this fear about respiratory depression is not reasonable. So, every time you use a pethidine or morphine dose, the patients would not go into respiratory depression. So, you have to uh, give a consideration to the pain that the patient is undergoing, and just calculate the situation and see whether the patient is at risk of going into respiratory depression. And another reason is fear of cardiovascular complications like hypotension, then fear of masking neurological signs and symptoms. So sometimes you will see the staff when they are maintaining head injury chart, especially when a patient is admitted after a trauma. Uh, they have a fear of whether the opioids that will be used on patients will mask neurological signs like pupillary signs or level of consciousness. So, in a situation like that, we can assess patients a neurological status like by assessing GCS, Glasgow Coma Scale, and then use opioids or at least some other means to control pain. Then another reason, a common reason, is fear of addiction to opioids by patients. So, which is again not fair. Patients would not get addicted to opioids just because one, two, three, or four doses have been used on them. Then, and sometimes the staff is not concerned about pain of a patient. So they are concerned about many other things, but not pain. And another group of staff, even if they are concerned about pains, they have a lack of knowledge about complications of pain. Now, earlier in this discussion, in this lecture, we went through several problems that a patient can have if patient's pain is not controlled properly. So sometimes staff is not aware about these issues, and sometimes the staff is aware about these complications, but they have a poor working knowledge. So knowledge is different to working knowledge. So a doctor with a good working knowledge would be able to assess pain quickly and will use analgesics accordingly and control pain and reassess pain and adjust the drug doses and frequency of drugs, may add a new drug, new analgesic, or remove another analgesic from the drug regime, and try to develop the optimal analgesic protocol or regime for that particular patient. Okay, now we are coming to the last and the fourth learning objective, which is how to treat pain in the hospital. So the big answer for that would be your approach for pain control or analgesia would be multimodal and multidisciplinary. So what do you mean by multimodal? Multimodal is trying to control pain using different modes, and multidisciplinary is that all the disciplines, or at least several disciplines that are dealing with managing of this patient, should try to control pain. For example, so disciplines examples of disciplines would be physician, mm, gynecologist, general surgeon, anesthetist, nurse, physiotherapist, dental surgeon, even the ward orderly or an attendant, whoever who is dealing with the patient should have a knowledge about pain and management. So in this slide, you can see the general approach for controlling pain. Now here I have tried to summarize or put pain management in a very simple manner under three headings. So uh, one important step to control pain would be to find the cause and treat the cause for pain. Another thing would be to control pain using pharmacological strategies. And the third one would be to control pain using non-pharmacological strategies. Coming back to the first one, so treating the cause. So if there's a cause for the pain, that should be addressed first. For example, if there's an abscess, draining an abscess should be a priority, and thereafter using antibiotics and analgesics. Cleaning and dressing of a wound if there's a chronic infected wound. If there's a fracture, you should reduce the fracture either as a manipulation under anesthesia or in the form of an open reduction and internal fixation, like that. There are other examples, so many examples. If the patient has an appendicitis, patient should undergo an appendicectomy. If the patient has a bowel obstruction, the patient should undergo a laparotomy and reduction of the bowel obstruction. If the patient has an enlarged, let's say, an ovarian cyst and twisted, and there's bleeding into the cyst, laparotomy should be done, or laparoscopically that cyst should be evacuated. So likewise, we should look for a cause with various diagnostic methods and try to treat the cause. If you do not treat the cause, it will be very difficult to control the pain by pharmacological and non-pharmacological strategies, because the cause, the root, is unattended, and it's quite dangerous to control pain with only analgesics, leaving the primary problem unattended. you might lose the patient's life if you do not treat the cause and just control pain with a strong analgesic, where let's say a big strong dose of morphine is given and the patient is now sedated heavily, and meanwhile the primary problem is brewing without being attended. So the second important strategy would be trying to control pain using drugs or analgesics. So there are many analgesics at your level. You should know the basic classification and examples for commonly used drugs. For an example, simple analgesics, paracetamol. So what I have put here as PCM is paracetamol, and NSAID is non-steroidal anti-inflammatory drugs. We'll be learning about those things in the next slides that will be coming. Then there are opioids. We have mild opioids, strong opioids. Examples of mild opioids are tramadol and codeine. Examples for strong opioids are morphine and pethidine. Then local anesthetics can be used to control pain, because pain finally will be felt in the brain and the thought and the mind. So pain is largely a thought and an emotion. So um, which is finally processed in the brain, and it is felt and interpreted by the mind. So if you use a local anesthetic to prevent messages regarding the injury that is happening at the periphery of the body, let's say in a fingertip or the forearm or at the tooth or in a bowel or in the ureter, if you are preventing impulses about tissue trauma or nociception, if you can prevent those nerve impulses reaching the central nervous system, the spinal cord, and the brain by using a local anesthetic infiltration or some other application, you can control a patient feeling pain. Then using regional anesthesia, let's say trigeminal nerve block for a um, trigeminal neuralgia, or using an epidural nerve block for labor pain. Then there are many other pharmacological strategies using Entonox, which is oxygen 50% and nitrous oxide 50%. So nitrous oxide is a strong analgesic gas, a painkiller gas, ketamine, and there are many other adjuvant drugs. So the third strategy to control pain would be non-pharmacological strategies. So under that I have mentioned psychological interventions as the first thing, and there are many other strategies. Now psychological interventions are very important for controlling pain, and for that matter in the treatment of any medical illness, any medical disorder. As doctors, we should always talk to the brain of a person, brain of a patient, to the mind of the patient, because uh, there's a large psychological element for brain, and with all other illnesses. So if we do not address the brain and the mind, thoughts, emotions of a patient, we will never be able to cure a patient. Whether you are managing pain or some other illness, you should always consider the patient is a human. He 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 has its own explanation in the mind. He has worries, concerns, he has questions. So you should talk to the patient's brain, thoughts, mind, and in his emotions. So under psychological interventions, I have mentioned a few here. So explanation is one simple strategy you can do. So you may be treating a patient's pain, you may be addressing the root of the patient's pain, but if you do not mention it to the patient, if you do not give an explanation, the patient would not know that you have understood his pathology, and a patient would not know that you are treating it. So for an example, if you are treating a patient's let's say cellulitis, tell them that this is a cellulitis, this is infection in the skin, and together with that you have germs in the skin and the subcutaneous tissues, and this can be cured. And you have inserted the intravenous cannula, you are giving some intravenous fluids like saline, and the fact that you are giving strong antibiotics maybe 3 times a day, and the fact that the patient has to keep, let's say if it's a cellulitis in a leg, to keep the leg elevated onto pillows, and the fact that this is not a cancer, and all kinds of things like that has to be explained to the patient. So then you are controlling patient's mindset, and you are helping him to cope up with the illness, and you are controlling patient's pain in a non-pharmacological strategy. Now, to tell these words, you don't need a drug, and it doesn't cost you. Cognitive behavioral therapy is another very important thing, which now to carry out cognitive behavioral therapy, a doctor or nurse should have some training in that. It's not easy to do by an ordinary doctor or nurse who does not have a training. So here we are addressing the patient's cognition. So as I mentioned earlier, pain is after all felt in the mind. It's largely a thought and an emotion. It's a very complex thought and a complex emotion. So by addressing the patient's cognition, you can control pain. Then there are many other methods like relaxation, meditation, distraction. And then there are several other methods. I'm not going to go into great details of those things. Just for sake of completion, I have mentioned a few here. Transcutaneous electrical nerve stimulation, or TENS, acupuncture, hypnosis, then elevation, say keeping, if the patient has, let's say the patient has undergone a surgery in the head and neck area, just keeping the patient's head propped up on a pillow will help reduce pain. That will enhance venous drainage. Or let's say the patient has undergone a surgery in the leg, keep the patient's leg elevated on two pillows. Or if the patient has a swelling in the arm, put a collar and cuff, or put some sort of tie and keep the hand elevated. So that will help to drain lymph, and it will enhance venous drainage, and all these things will lead to reduction of edema, swelling, and will be helpful in controlling pain. A very simple thing. Similarly, massaging, rubbing, using hot water bottle, or using ice packs, splinting, immobilization, all will be very helpful in managing pain. Right now, let us look at principles of managing acute pain. Now, as doctors, we will be encountering acute pain very frequently, more frequently than chronic pain. So, for instance, patients might come with natural illnesses. Let's say the patient may be having a headache or a toothache or an abdominal pain, or the patient may be soon after a trauma or soon after a surgery or any other medical procedure. All these things will be associated with acute pain. So pain may be mild, may be moderate, may be severe or excruciating. And so next thing is to consider whatever the injuries or the illnesses that the patient has. Then look at the comorbidities that the patient has. So what do you mean by comorbidities? Other morbidities, other illnesses the patient has, like whether the patient has high blood pressure, diabetes, ischemic heart disease, renal impairment, liver impairment, or allergies to medicines, etc. Age and other things. For instance, whether this is a child, a neonate, an adult, or an elderly. We have to consider the side effect profile of drugs when we are using drugs on patients, analgesics on patients. Sometimes some of the analgesics, their side effect profile may not be good for you to use that on an elderly patient, especially if he has other comorbidities. Then look at the other points. So assess the severity of the pain. So if the patient has a mild pain, maybe you can get away by giving only one analgesic, whereas if the patient has a severe pain, you might have to just use 3 or 4 drugs together with non-pharmacological strategies, and you have to look for a cause and treat it. And one of the very important things that you should do when you try to treat pain, is you have to believe the patient. Don't ever say no, that patient can't have that much of pain with an illness like this, or with a trauma like this, or with a surgery like this. Pain is what the patient says is hurting him, not what the doctor thinks how much of pain should be there. So it will be very wrong for a doctor or nurse to say, no, there can't be that much of pain with this illness. So it is the patient's expression that we have to believe and treat, and ignore less important issues like fear of addiction to opioids or any other drugs when it comes to managing acute pain. Maybe you have to consider those things if you are trying to control a chronic pain. If you have to prescribe analgesics for several weeks or a month or two for a patient, maybe you have to consider about addiction and other uh, side effects. But when it comes to managing acute pain, so it's going to be a pain that is going to last for a few hours, maybe 1 or 2 days, and some of those concerns may not be very important if you are going to manage pain over a very short period of time. Then again, as I mentioned earlier, managing pain has to be with a multimodal approach where you use more than one drug. Well, I'm not saying that you have to use 3 or 4 drugs for a simple pain. If it is a simple pain, let's say a simple headache, you might be able to control it only with paracetamol. And prompt action is necessary. So what do you mean by prompt action? Taking measures immediately, not later, not by the next doctor, not by the doctor who will be seeing the patient in the night, or the doctor who is supposed to come tomorrow, or not by your specialist who will be coming later. So treat the patient's pain now, not later, and use adequate doses of correct combinations of drugs now. So don't underdose a drug. Use the correct combinations at correct intervals. So get on top of pain by using correct doses, correct combination at correct intervals. And if you're worried about the side effects, you can reduce the drug doses or the number of drugs that you are going to use later after controlling pain. Another very important thing that you should bear in your mind when you are managing acute pain is that there's a wide range in perception and interpretation of pain. So what do you mean by that? So for example, if 5 patients have undergone the same surgery, same operation, these 5 patients would have 5 different intensities of pain. So one patient may be shouting in pain, one patient may be crying silently in pain, other patient may be just having very mild pain with that. Next patient may be fast asleep uh, after having the same undergoing the same operation. So there's a wide range, and pain is personal to a reasonable degree. Therefore, you have to understand this spectrum of perception. So, don't think that a patient who is shouting and crying in pain is a trouble to you, and at the same time, don't think that the patient who is quiet and sleeping is a very good patient. So, both patients may be having pain or may be having other concerns that may be the reason for a patient to be very upset or crying or shouting. Talk to them, assess pain and assess other problems, try to understand the pathology and the theories behind these things, and control pain. And especially when you are confronted with a patient with acute pain, try to get on top of pain, try to control pain totally by using correct doses of correct combination of drugs with precise timing, using them on a regular basis, control pain, and then later you can come down on the drug doses. Now, there's a famous pain managing guideline laid by the WHO, which is called the WHO analgesic ladder. So, I expect all of you to read about the WHO analgesic ladder. And in this ladder has 3 steps, where the lowest step would talk about using simple analgesics, and the next step would talk about using drugs with moderate efficacy like moderate simple opioids. And the third step would talk about using strong opioids. So that ascending ladder is good for chronic pain, a pain that has been there for some several months or several weeks, and you are going to see the patient repeatedly in your clinic or in your consultation chamber. So you can prescribe some simple drugs first, like let's say paracetamol and non-steroidal anti-inflammatory drugs first, and you can ask the patient to come in several days time or a week or 1 month or whatever, and then see how the patient's pain is. And then if the pain is not properly controlled, now you can escalate your treatment and move on to using a little stronger drug like a mild opioid, like say paracetamol plus codeine or tramadol. And then you can see the patient after another interval and see if it is not adequate, you can escalate on analgesics further. But when it comes to acute pain is not going to last so over several days or several weeks or months like that. It will be there maybe for several hours of severe pain, maybe 1 or 2 days, like a patient who has met with a road traffic accident or some other trauma, or a patient who is after a surgery. He maximally will have pain over a few days. So one very important thing in controlling acute pain is getting on top of pain where you are coming down on the WHO analgesic data, uh, where you are using strong analgesics in a good combination. First, let's say morphine together with non-steroidal anti-inflammatory drugs and paracetamol together, and controlling pain, and later you can come down on the ladder. Say for an example, you have a patient who is after a massive facial trauma, and so what would be a good combination of analgesics for this patient? We can use a strong opioid like morphine, 0.15 milligrams per kilogram body weight. We can use it subcutaneously in the ward setup or intramuscularly. Subcutaneous is better than intramuscular, not as an intravenous drug in the ward setup. Intravenous route is for anesthetists to use in the operating theater and the intensive care unit where there's resuscitation facilities freely available. So use morphine 4 to 6 hourly, or if let's say the patient has a history of bronchial asthma, so you don't want to use a drug like morphine which has histamine releasing property, so you do not want to have an exacerbation of asthma in this patient, so you can use a dose of pethidine intramuscularly, 1 milligram per kilogram body weight, maybe 2 to 4 hours. So pethidine acts for a shorter period of time compared with morphine. So, and at the same time, use paracetamol or paracetamol together with codeine. So we have brand names like Rapidine and Panadine for that. Unfortunately, we do not have codeine alone to be used. So we always have the combined tablets like paracetamol together with codeine. And you can always use a non-steroidal anti-inflammatory drug like diclofenac sodium or ibuprofen, and local anesthetics. You can also use tramadol if you have once you have stopped using morphine. Right now, one of the first things that will be going through the mind of a member of a staff the moment that they have to use a strong opioid on a patient like morphine or pethidine would be whether the patient will have hypotension, respiratory depression, or sedation due to the morphine or pethidine that you are going to use. Well, it is good to be concerned like that, but look at the scenario. How much of pain has the patient got? What is the intensity of pain? And what is the possibility of the patient having those side effects? Let's say your patient is in severe pain, he's crying or yelling or shouting in pain. That kind of patient, or even if the patient is not crying, if the patient has so much of pain, severe pain, let's say you have assessed the pain with the numerical rating scale and he says his pain score is 10 out of 10 or 9 out of 10, or let's say 8 out of 10, so he has lot of pain. So that type of patient is not going to have hypotension or respiratory depression or sedation due to an morphine or pethidine dose that you are going to use. So who is the patient who is going to get that kind of adverse effects? It will be a elderly patient or a weak patient, critically ill patient who may be already asleep, who has less pain. That is the type of patient who will get hypotension or respiratory depression or oversedation due to an opioid that you are going to use. So always look at the scenario and see whether it is possible for the patient to have adverse effects due to analgesics in the current scenario. Okay, so let's try to go into a little more detail. So how to treat pain? As I mentioned earlier, our approach should be multimodal and multidisciplinary, looking for a cause and treating the cause, pharmacological strategies using analgesics, and non-pharmacological strategies where you do not use analgesics, but you use other methods. So one of the very important analgesics is paracetamol. It's freely available and very frequently ignored by the health staff. So lots of health staff thinks that paracetamol is a useless drug, or it is of no use, so it is not effective or something like that, which is totally wrong. Paracetamol is a very effective analgesic provided it is used in the correct manner. So the advantages of paracetamol is it can be given to all patients regardless of the site of pain, type of pain, or the severity of the pain. You can give it for headache or pain in the big toe or in the thigh or wherever. You can give it for mild pain, moderate pain, or severe pain. So for mild pain you can give only paracetamol. For a moderate pain you can give paracetamol plus non-steroidal anti-inflammatory drugs. For severe pain you can give paracetamol with an NSAID and with a dose of morphine or pethidine, and it is very effective when given regularly, maybe 6 to 8 hourly. And you can give paracetamol orally, or if the patient cannot eat and drink, if the patient has a nasogastric tube, you can pass it through the nasogastric tube after crushing it. There are rectal suppositories of paracetamol, and there is intravenous paracetamol which is very effective, which will act very fast also. Only disadvantage with IV intravenous paracetamol is it is expensive. So the average dose would be 15 milligrams per kilogram body weight per dose. Ideally, paracetamol should be given 6 hourly, but in our hospital setup, for patients who are admitted to the hospital, generally analgesics or other drugs are administered only 3 times a day. So paracetamol can be given 8 hourly. For a really needy patient, you may give it 6 hourly. But even if you give it 8 hourly or 3 times a day, even that generally is enough. So as I mentioned earlier, paracetamol is a very effective analgesic, especially when it is used regularly in correct doses. And paracetamol will be helpful to reduce the dose or frequency of other strong analgesics. For an example, morphine. Now we know morphine is a very strong analgesic, and at the same time all of are not very happy about the side effect profile or adverse effect profile of morphine. It can occasionally cause respiratory depression, can occasionally cause hypotension, can cause oversedation of a patient. But therefore, if you are using morphine together with paracetamol, if you are using morphine together with an NSAID and paracetamol, you can reduce the need of morphine with time. So later you might be able to manage pain only with paracetamol without morphine. So even if a patient is fasting for surgery, in the preoperative period, you can still use paracetamol with a sip of water. Maybe 2 hours before a general anesthetic, you can still use paracetamol. Paracetamol is a very cheap drug and it's freely available in all hospitals, even in all government hospitals. And it has only a few absolute contraindications like non hypersensitivity or allergy, and liver impairment. Again, if a patient ever complains about an allergy or hypersensitivity, just double check with the patient whether he or she is truly talking about an allergy. Sometimes patients refer to side effects as allergies. And for an example, a patient might say, when I use paracetamol, I have an allergy. So just ask the patient, what is the allergy you are talking about? Now he might say, well, I have gastritis. So that's not an allergy, that's a side effect of paracetamol. You can evade that, you can avoid that side effect by asking the patient to take paracetamol soon after meals, not before meals, not in between meals. Another very important thing about paracetamol is you have to be very careful, cautious about paracetamol poisoning, especially when you are using paracetamol on an elderly or in a critically ill patient or on a child or on a patient whose body weight is less. If you are not very careful, with a few extra doses, extra 2 3 doses, a patient can end up getting paracetamol poisoning. So remember the dose, 15 milligrams per kilogram, 6 to 8 hourly. So per day maximum dose would be 90 milligrams per kilogram for an adult, and for patients below 1 year, infants, the routine regular dose would be 10 milligrams per kilogram body weight, not 15, and their maximum dose per day would be 60 milligrams per kilogram body weight. NSAIDs or non-steroidal anti-inflammatory drugs are another group of very effective and useful analgesics. So in addition to their analgesic properties, they have anti-inflammatory properties. They are good at controlling inflammation, for example, in arthritic diseases, rheumatoid arthritis or whatever other arthritic disorders. They have an antipyretic property where they can bring down temperature, and they also have an antiplatelet action. So aspirin is used for its antiplatelet action on lots of elderly patients with various cardiovascular diseases. So if you are preparing one of your patients for surgery, just double check whether they are on aspirin regularly, and consider for stopping aspirin, because they can lead to uh, unnecessary bleeding during a surgery, or in the post-operative stage. And at the same time, you have to outweigh the risks of stopping the antiplatelets or aspirin, and then facing to effects due to stopping aspirin also. So NSAIDs are very effective analgesics for mild to moderate pain of somatic origin. So for example, pain arising from skin, subcutaneous tissues, muscles, joints, tendons, ligaments, bones. NSAIDs are very good for pain arising from those structures. And effect is more, effect is better when NSAIDs are combined with paracetamol, and avoid using two NSAIDs together. So don't use par, uh, diclofenac sodium and ibuprofen together, because both are NSAIDs. Then you are just adding the side effect profile. You are not, your approach is not multimodal when you are using two NSAIDs. Still the approach is unimodal, because both drugs are acting through the same channel, through the same mode. So it's a unimodal approach, and you are adding side effects. And NSAIDs can be used orally or nasogastrically, rectally, or intravenous mode. Also, intravenous NSAIDs are not available in the government sector, but it is available in the private sector. Parecoxib is a intravenous NSAID available here. So there are many NSAIDs. Select the best one for your particular patient. So there are largely two main groups of NSAIDs. First one is the non-selective group, which inhibits both COX-1 and COX-2 enzymes. The next one is COX-2 selective NSAIDs. So examples for non-selective NSAIDs are ibuprofen, mefenamic acid, diclofenac sodium, indomethacin, aspirin, methyl salicylate. Those are the most commonly used ones. Examples for COX-2 selective ones would be celecoxib, etocoxib. So they have less gastrointestinal effects, less bleeding, and renal side effects. Tramadol is another very important analgesic. It has both opioid and non-opioid actions. It is good for moderate to severe pain. It can be used as an oral drug, or there are rectal suppositories. It is available in parenteral form, so you can use it as an intravenous or intramuscular drug. It has minimum respiratory and cardiovascular effects, and the oral dose for an average built adult would be 50 to 100 milligrams 3 to 4 times a day. Initially, to control pain, maybe you can give 50 to 100 milligrams every half an hour to every hour till you control pain. And for a patient who is after a head injury, and if we are concerned about his breathing being affected by morphine or pethidine, we can still use tramadol on that patient. Codeine is a mild opioid which is effective for mild to moderate pain. The standard dose would be 30 to 60 milligrams every 6 hourly. And common side effects of codeine are constipation and drowsiness. Unfortunately, codeine is not available as the free drug in Sri Lanka. It's available only as a combined drug with paracetamol as rapidine or panadine. Each rapidine or panadine tablet has 8 milligrams of codeine. Strong opioids. So strong opioids are an essential component of the drug regime used for managing severe pain. So strong opioids are available both in oral form and the parenteral form. Parenteral form is when you use strong opioids as intravenous, intramuscular, or subcutaneous drugs. For an example, oral morphine is used for severe cancer pain in terminally ill patients, and parenteral opioids like IV morphine or IV pethidine or IV fentanyl are used in the operating theatre and the intensive care unit by anesthetists, and subcutaneous or IM morphine will be used in wards, surgical casualty wards, in the post-operative wards for managing acute severe post-operative pain or pain due to trauma. And intramuscular pethidine is again commonly used in the trauma setting and surgical ward setting for managing acute severe pain. So when you compare NSAIDs and opioids, NSAIDs are good for mild to moderate pain, largely of somatic origin. So as I mentioned earlier, for pain originating in skin, subcutaneous tissues, muscles, joints, bones, etc. And NSAIDs are not very good for managing visceral pain, whereas opioids are very good for managing visceral pain and somatic pain both. And also, strong opioids are a very effective tool for managing severe pain or moderate to severe pain. So they are very effective analgesics. There are a few concerns regarding their side effects. So the commonest side effects would be nausea and vomiting, and it can lead to constipation also. And a lot of staff members are very concerned about excessive sedation, respiratory depression, and hypotension that can come with strong opioids, especially when it is used in the ward setup. In the operating theatre and the intensive care setup, well, in the operating theatre, an anesthetist would be using the patient on a patient who is anesthetized. So sedation is not an issue. Respiratory depression and hypotension are not issues because he's concentrating on that particular patient, and the anesthetist is capable of managing induced respiratory depression and hypotension. But in the ward setup, staff has concerns about these things. But as I mentioned earlier, If you use those drugs carefully on selected patients, they are very effective analgesics and are quite safe. They are quite safe. Opioids can lead to pupillary size changes. So, pethidine can lead to dilatation of pupils. Morphine can lead to constriction of pupils. So, obviously, with this changes in the pupillary size and causing sedation, it can affect neurological assessment, especially if you are monitoring a patient with the Glasgow Coma Scale. But this doesn't mean that we should not use strong opioids for pain relief in patients who are after trauma just because we are monitoring them on a GCS scale. So, what we should do is we should assess the patient's neurological status in terms of GCS or any other scale, and analyze the possibility of head injury also, and still we can use opioids and control pain. And we may use tramadol even in head injured patients, because tramadol would not stop breathing of a patient if it is used carefully. Strong opioids. So examples for commonly used strong opioids are morphine, pethidine, and fentanyl. So morphine is one of the strongest opioids, and the dose to be used in the ward setup would be 0.15 milligrams per kilogram body weight, 4 to 6 hourly, subcutaneously or as an intramuscular drug. It generally starts to act in 5 minutes. Peak action would be in 20 minutes. Pethidine has a slightly quicker onset of action, and the dose would be 1 milligram per kilogram body weight. The duration of action is a little shorter, 2 to 4 hours, and it can be used as an intramuscular or intravenous drug. Fentanyl is several times more potent than morphine, therefore, the dose is in micrograms. 1 microgram per kilogram body weight acts for about 30 to 40 minutes when it is given intravenously, and it acts quite fast. It starts to act within 2 to 5 minutes. So morphine is a very potent analgesic. It has a high efficacy. So what we mean by efficacy is the ceiling effect, the maximum effect that you can achieve with a drug. So it has a very high ceiling effect, but it is sparingly used, unfortunately, by staff due to unfamiliarity. So, generally, when there's a need for morphine, staff generally uses pethidine in place of morphine, whereas morphine is the better drug. It is a stronger drug which acts for a longer period of time. So, morphine is very good for patients who are after trauma and after surgeries, pain. Well, it's true that morphine has an addictive property, uh, and it can be abused by staff also. Some patients also can get addicted if you happen to use it very frequently over several days to several weeks, but it's not a big issue when it comes to managing acute pain. A patient would not get addicted to morphine just because you have used several doses on the patient, maybe 3, 4, 5, 6, 7 doses. It doesn't mean that the patient is going to get addicted to morphine. So morphine sulfate is used frequently on cancer patients, especially when they are undergoing palliation or palliative care. Two big problems that you can encounter when you are using in palliation is patients developing tolerance, where you have to keep on increasing the dose. Let's say you start with 5 milligrams 3 times a day, and you may use it 30 milligrams 4 hourly after a few weeks' time. And another big problem is patients developing constipation. So you'll have to use a laxative like Bisacodil on a regular basis, maybe night on every day or twice a day with oral morphine sulfate. Ketamine is another very useful strong analgesic,
and it can be used in several circumstances. For an example, it can be used in extrication of trauma victims from a road traffic accident or any other injury. It can be used in field anesthesia in battlefields or fire fields. It is quite a useful drug during transportation of patients to the hospital and within the hospital, transferring patients on trolleys for x-rays and CT scans and for various other destinations where transferring will be very painful. And it is especially useful for positioning of patients for various procedures, especially when the patient is after a trauma. And it is a quite useful drug in patients who have sustained burns, especially when they are undergoing changing of dressings, cleaning and dressings of wounds, wound debridements very frequently. So intramuscular ketamine can be used in the ward setup. It is a very useful analgesic in the post-operative setting also, and ketamine is available in forms also. There's intravenous ketamine, and the same solution can be used as an intramuscular drug. And there are ketamine lozenges that can be given for children to kept in the mouth and suck or chew. And one special advantage with ketamine is it will preserve spontaneous breathing. It will preserve protective airway reflexes. So the chances for a patient to get too obtunded and sustain pulmonary aspiration is very remote. And it will also maintain hemodynamic stability. Generally, ketamine will lead to a tachycardia and an increased blood pressure, whereas other strong analgesics like morphine and pethidine can cause hypotension. So ketamine is very effective when it is used even as an intramuscular drug, especially when intravenous access is difficult. If there's a difficulty in getting into a vein, you can still use ketamine as an IM drug till you gain access to a vein. And it is a good supplement for other analgesics. While you are using NSAIDs, paracetamol, or opioids, you can use ketamine, and it will be useful to bring down the doses of other drugs. And if you have given ketamine for a patient for analgesic purposes, later it can be extended for anesthesia by using intravenous ketamine, and it can be repeated also. Well, ketamine dose would be 10 to 15 milligrams at a time intravenously. Can be used as an intramuscular drug also, can be used in a continuous infusion 10 to 40 to 50 milligrams per hour. There are ketamine lozenges which can be given for children or even adults to suck in the mouth, 25 milligram lozenges. And ketamine can occasionally cause hallucinations and even delirium. So local anesthetics are another very important group of analgesics. They are very effective analgesics. Now, if you can remember at the beginning, we discussed that final processing of pain happens in the brain, and final interpretation as to whether this nociception is painful or not will be done in your mind. So, pain is largely a thought and an emotion uh, which is processed at the brain through the mind. So, if we can stop impulses regarding nociception entering the central nervous system by using local anesthetics, interrupting nerve messages entering the spinal cord or the brain by using local anesthetics, then we can at least minimize, reduce patients feeling pain. So, local anesthetics can be used for local anesthesia and regional anesthesia, both, and they have less systemic side effects when they are used carefully. So, for an example, lignocaine can be used as a transdermal drug for contusions and burns, and you can use lignocaine for local infiltration for a wound cleaning and a wound dressing. Regional analgesia is another important way of controlling pain. So, local anesthetic agents can be used to have local anesthesia or regional anesthesia. What we mean by local anesthesia is using a local anesthetic agent to control pain in a small locality, in a restricted area. Whereas in regional analgesia, you are using local anesthetic agents to block one big region. For an example, using trigeminal nerve blocks, you can block either the whole trigeminal nerve or a branch of it. For an example, maxillary branch or the mandibular branch or supraorbital branch, to block the area supplied by that particular branch of the nerve, or using an epidural block. For an example, using a lumbar epidural to control labor pain or pain from a laparotomy, or a thoracic epidural block to control pain from a procedure done in the thorax. Then again, peripheral nerve blocks for limb injuries. For an example, you can do a brachial plexus block for an upper limb pathology. Okay, we have come to the end of the lecture, and so we will summarize what we learned. And we first went through the definition of pain, where we learned there are many definitions, and the most widely used definition is the definition given by IASP, which says pain is an unpleasant sensory and emotional experience associated with tissue damage or potential tissue damage. Then we also learned about adverse effects of pain, deleterious effects of pain, where we learned pain affects entirety of a person. It affects the health of a person, and the health also we learned that it will affect all facets of health: physical health, mental health, social health, spiritual health. And it will affect a person's personal life, family life, social life, the whole society, and the whole country, and the health system. Then we also learned how to assess pain. It is very important to assess pain, and we have to bear in our minds that almost all procedures we do on patients, all medical procedures, be it for diagnosis, be it for treatment, all those are going to cause pain to patients. Secondly, quite a lot of medical illnesses that patients present with also have pain. So not only surgeries and trauma that is going to cause pain, quite a lot of patients who present with medical illnesses also have pains. For instance, patients who come with arthritis, they have a lot of pain. Patients having pneumonia, they have pain. And anyway, if it is a surgical patient, especially if a patient is after trauma or after surgery, you have to bear in your mind that they are having pain, maybe a lot of pain. So assess pain and give a thought about pain, then plan to control pain. So next is how to manage pain. So under that we learn that we have to look at three aspects. One is to look for a cause, and treat the cause. Then we have to look at controlling pain using analgesics, that is pharmacological management of pain. Thirdly, non-pharmacological management of pain. Under that we learned there's a large role to be played by handling the patient's mindset, his mind, his thoughts, his emotions, because pain is, after all, it's largely a thought, it's an emotion. So if you do not address that emotional aspects, psychological aspects, you are failing in your pain management. Don't think that you can control pain by giving a big dose of morphine, or starting a patient controlled analgesia, or only by using an epidural analgesia. It's good to start those things. It's good to use modern technology. It's good to use morphine, which is a very strong analgesic. It's good to use a combination of morphine together with paracetamol and NSAIDs, and with a regional anesthetic block. But your pain management is never complete if you haven't talked to the patient and explain what the pathology is, what the possible cause for this pain is. And if you do not explain him the fact that you are attending to his pain, and the fact that you have understood his problem and you are treating him and you are concerned about him, so there is a large place for psychological interventions when it comes to pain management, and for that matter, managing any medical condition. Thank you very much.